Hello and good morning. This is on a very common topic, and in fact, a very sought after topic, that is a non-operative management of colorectal cancer. The colorectal cancer being very common, people do have issues with the surgical management of colorectal cancer due to its dysfunctional outcome, especially with regards to sexual, bowel, and urinary symptoms. So, what is the current standard in most countries and across most guidelines would be that all high-risk colorectal cancers, especially the rectal cancers, undergo neoadjuvant therapy, which is followed by radical resection, that is in the total mesorectal excision. The local recurrence following this treatment choice is usually less than 10%. And the problem, as I said before, is that you do surgery, there is a perioperative morbidity and very occasionally mortality. Bowel, sexual, and urinary dysfunctions are things that people do not tolerate well, and also affects the quality of life. And also, it sometimes requires the permanent stoma, which is a serious lifestyle change for the patient. So, at one point, there was a paradigm shift. It was Nakagawa as well as Professor Angelita Habagama, are the ones who pioneered. In fact, Angelita Habagama is world over renowned for her pioneering work in this entity. She's a Brazilian professor who found out that there is a significant complete pathological, or in fact clinical, response in patients who get this neoadjuvant treatment. We all know that anal cancer responds quite well to radiotherapy, and it's quite less in the case of adenocarcinomas. But even in adenocarcinoma, that is rectal cancers, up to about 1/4 of patients, up to 10 to 25% of patients, do give a complete clinical response. And Angelita Habagama has a famous study, all retrospective, 265 study participants who had neoadjuvant chemoradiotherapy were reviewed at 8 weeks with clinical, endoscopical, and also imaging assessments. And 71 had complete clinical response, and they were followed up for more than 4 years, and only 2 had local recurrences, and 3 had systemic recurrences. So these are significant findings, even though they are not backed up by level 1 evidence. It's still very important to shed light on that. Another point is that you find, there's a study coming off from USA, that what do patients require when they go to get treatment for their cancer. In their setup, not having a permanent stoma was one of the main reasons, or in fact expectations, that the patient have, even more so beyond achieving a cure for the cancer. So this is another important finding. So with this scenario, most of the Western medical specialties went towards thinking of non-operative management. So gradually, non-operative management became an option, but still these challenges were there. Is that available data stems from retrospective studies, and the imaging that is used was not a good representation of the current disease. And complete clinical response does not always mean complete pathological response, and it required meticulous and frequent monitoring, whereas in surgery, following surgery, the follow-up is not that stringent, and salvage surgery can be challenging than an upfront surgery. So these challenges were laid in front of them when they embarked, and also contemplated on watchful waiting. So this complete clinical response is not equivalent to a complete pathological response. Is thought to be one of the main challenges that they had to negate, and they had to come across. So trials are at the moment conducted to find out options and modalities that are better in assessing whether there is a complete clinical or complete pathological response. So that results in this kind of an approach, but it is deemed to fail if the patient is not fit for a radical surgery. Then non-operative management per se is not going to be an option. It's in fact definitive chemoradiotherapy. And patients who don't want an APR at all costs are not suitable, and also early low-risk tumors are not taken up for this kind of an approach. So who is it suitable for? Low rectal tumors around 7 centimeters or below, and high-risk tumors, T2 or more, in fact more than T2, MVI positivity and lymph node positivity, and CRM involvement and threatened CRM. So high-risk tumors, these are more suitable for non-operative management. Furthermore, why not upper rectal tumors? Because of radiotherapy and effects of radiotherapy, there'll be pelvic fibrosis, and salvage surgery is going to be very difficult. So the morbidity is going to be more, and there is no advantage of sphincter preservation, and the data is also quite poor with regards to this entity of patients. This is just a representation of the treatment platform, treatment, in fact, how it is catered to, and early tumors like T1, T2 can undergo local resection, and there are significant pathological findings, may require adjuvant treatment or a TME depending on patient requirement. And in trigger trial that is carried out in Royal Marsden and UK centres, the low rectal tumors with CRM involvement or T3C tumors, CRM involvement, EMVI positivity, N1C tumors, those are enrolled into the trigger trial, control arm, intervention arm, and the intervention arm, they have good response, watch and wait policy, poor response, consolidation, chemotherapy, and then looked into the response, and if the response is good, continue watchful waiting. And T3A and B and CRM is clear, EMVI negative, those patients can be offered complete upfront surgery as well. So what is the neoadjuvant therapy that is given? Do we give the usual routine type of neoadjuvant treatment, or do we give anything special? Yes, it's in fact there are two options: the short course radiotherapy and chemoradiotherapy in the rectal cancers. Which one do you give? With the evidence, the German rectal cancer trial, about 8% complete pathological responses has been seen with neoadjuvant therapy. So that is going to be the best option. In short course radiotherapy, the evidence is much less, and it's about 1.7% that is with the available evidence. So the consensus agreement is a high dose of chemoradiotherapy with 5-fluorescent capecitabine, Folfox, and with radiotherapy about 30 fractions is suggested. That's more of an agreement. When do you assess it? There's no evidence, no clear-cut consensus either. About 6 to 12 weeks is thought to be the better time, but in fact up to 16 weeks there is a very good response, and the response continues. How do you identify it? Digital rectal examination, EUS, MRI, PET-CT, and transanal excision endoscopic microsurgery can also be offered to assess whether there is a residual tumor. But what is taken up in NCCN is a digital rectal examination, that is clinical, radiological, and endoscopic assessment. So in the DRE, there should not be any ulceration, masses, induration, or any form of irregularity. In the case of an endoscopy, there should not be any mass, induration, ulceration, or mass lesion. It's just the thin, or in fact flat, fibrous scar, whitish scar with telangiectasia that might be seen. And this kind of a scenario, when you have it, you do MRI or PET-CT. MRI is widely accepted, and MRI Mandard regression score or tumor regression score, T2 weighted images, and EWI increases the sensitivity according to the Maker trial. Referral of surgery trial has shown that about 30 to 60% gets wrongly interpreted in the PET-CT. So PET-CT is differed in certain centers, especially in the Europe, but in US still the PET-CT is thought to be superior. About 30 to 100% sensitivity increase happens with PET-CT in certain units as well as in MRI. But most widely believe that MRI is thought to be the best modality of assessment of complete clinical response in patients who have DRE and clinical findings. So They give this TRG score, TRG 1 to 5. 1 is just in fibrosis with low density signal on T2-weighted images with no evidence of immediate signal intensity. And the T2, the fibrosis is quite denser, and low signal fibrosis in T3 with macroscopic scattered or local intermediate signal intensity, and it worsens. And TRG5, in fact, very poor response. There will be no fibrosis present. So monitoring is just from the deferral of surgery trial, how they did the follow-up and monitoring. It's a very stringent and very meticulous follow-up for 4 to 8 weeks of follow-up initially, and then gradually increased. But see, the MRIs, the FDG PETs and CTs and all that was done very regularly, and it is not going to be an easy procedure for the patient to follow up this meticulously, but it can be done. So there is again no consensus on how to follow these patients up. There is no level 1 evidence. These are the future issues that we're going to face, and the TRIGGER trial is going on. It's looking at the MRI TRG score as a biomarker for response of total neoadjuvant therapy, and it's still underway. We'll have to wait and see what kind of prospective evidence that they will come up with regards to changing the landscape of patients who are managed in this manner. This is just a schematic presentation of how they would consider of the follow-up and in fact management of these patients, with the same findings after randomization. MRI scan, TRG 1, 2 patients can be followed up with watchful waiting, and TRG 3, 4 consolidation chemotherapy, and then looking at the response, decide on watchful waiting or surgery. So proponents of non-operative management says patients who are undergoing operative management have a survival rate of 3-year survival rate of about 93%, whereas 90% in the patients undergoing conservative management, which is not a big stretch or in fact a big difference. Evidence, even though is very few, that is the pooled evidence, what the pooled evidence suggests. So that is a significant finding if there is no difference in the overall survival. And also, how can we do the salvage surgery as an organ preservation? It is still possible in most of the West centers in the West, and also the incidence of metastasis in patients who are undergoing surgery and non-surgical management is almost the same, and there is no difference. So if we have a worry that this tumor might spread while we are managing the patient with non-operative management, well, it doesn't. The evidence does not suggest so. That is an important finding as well. So the proponents are contemplating on these facts, and evidence is the main issue. The quality of evidence is not there. So potentially it's a very attractive option, especially for the patient who are not having any dysfunctional lower rectal and sexual dysfunctions, but needs a confirmation with better evidence, and need to have an MDT or multidisciplinary team approach and super specialization, and decide on case-by-case basis with meticulous follow-up of patients. So patient compliance becomes a mandatory factor, as well as availability of certain facilities readily. So these are the important things to note about non-operative management. It's still a growing subject, so keep an eye, and thank you for listening. Wish you, these are my references. Wish you all the best, and if you have questions, please do post them in the comment section below. And thank you for listening. We'll see you again with a similar presentation. Thank you.